We're going to go over today Unit 5, some of the notes that I want to give you to prepare for your Unit 5. And it's a long unit, as I'm sure you've seen, kind of detailed as far as nervous system, that sort of thing goes, but we'll get through this here in this setting. So first we'll start with Chapter 10, the nervous system. And the nervous system is the nervous tissue in the brain. The structures of the nervous system are divided into two parts: the central nervous system, or the CNS, and the peripheral nervous system, which is called the PNS. The CNS includes the brain and the spinal cord. The CNS is located in the dorsal cavity. The brain is located in the cranial cavity, and the spinal cord is enclosed in the spinal cavity. The peripheral nervous system is located outside of the CNS and consists of nerves that connect the CNS with the rest of the body. There are three general functions of the nervous system: sensory, integrative or interpreted, and motor. The types of cells that make up the nervous system: the first is neuroglia, or we call them glia cells, and they're the nerve glue. These cells support, protect, insulate, nourish, and generally care for the delicate neurons. We call those glia cells. Two of the more common glia cells are astrocytes and epidermal cells. Astrocytes are the most abundant and have the most diverse functions. They support the neuron structurally and cover the entire surface of the brain and help form a protective barrier called the blood-brain barrier. And you'll hear that a lot because that protects the brain from any potential toxins and a lot of other functions, but you'll hear about the blood-brain barrier. The ependymal, that's a hard word for me, ependymal, lines the inside cavities of the brain and assists in the formation of cerebrospinal fluid. Another type of cell that makes up the nervous system are neurons. Neuron is the most important in the transmission of the electrical signals. Parts of the neuron include the dendrites, the cell body, and the axon. The dendrites receive the signals from other neurons and transmit the signals towards the cell body. The cell body contains the nucleus and is essential for the life of the cell. And the axon is a long extension that transmits signals away from the cell body. The axon is made up of the myelin sheath, and you will hear that again, and that protects and insulates the axon. The neurolemmal and the nodes of Rayvier. The myelin sheath are long nerve fibers of both the peripheral nervous system and the central nervous system, and are encased by a layer of white fatty material called the myelin sheath. You will hear that. The myelin sheath protects and insulates the axon. It's a white fatty material that lines the sheath. The nerve impulse is an electrical signal that conveys information along a neuron. The nerve impulse is called the action potential. There are two phases of the action potential: depolarization and repolarization. You need to look at figure 10.5 and follow it through the events of the action potential from its resting state to depolarization to repolarization, and make sure you understand that. In the polarization or resting phase, the insides of the cells are negative. Remember that. When the nerve is stimulated, depolarization occurs and the inside of the cells become positive. Then, when the nerve impulse rests again or repolarizes, the inside of the cells revert back to being negative. What causes the nerve to be stimulated? The permeability of the neuronal membrane changes in a way that allows sodium ions to diffuse rapidly across the membrane of the cell, carrying with it a positive charge. So when sodium comes in to the cell, it changes it from a negative to a positive because of the sodium. Thus, it is a rapid inward diffusion of sodium, and that causes the depolarization. Repolarization stops additional diffusion of sodium into the cell, and it allows potassium to rapidly diffuse out of the cell. So it stops the sodium from coming in and it pushes out the potassium. The outward diffusion of potassium decreases the positive charge that's inside the cell, leaving behind the negatively charged ion. So that's how it reverts back to being negative. Thus, the outward movement of potassium causes repolarization and a return to the resting state. The inside of the cell is now negative again. The nerve impulse. What causes the impulse to move rapidly? The myelination increases the movement of the nerve impulse along the axonal membrane. Remember that the axons of most nerve fibers are wrapped in that fatty substance that we talked about. At the nodes of Ranvier, the axonal membrane is bare, or it's unmyelinated. So at the nodes of Ranvier, remember, that has no fatty protection on it. The nerve impulses arrive at the axon from the cell body that cannot develop on the membrane that's covered with a myelin. The nerve impulse can, however, develop at the nodes of Ranvier, the bare axonal membrane, the one that doesn't have the fatty membrane. Thus, in a myelinated fiber, the nerve impulse jumps from one node to the other node, node of Ranvier, node of Ranvier, and that causes the impulse to move along. The book described it much like a kangaroo jumping from one end to the other end of the axon. This jumping node to node is called salutatory conduction. Salutatory conduction increases the speed with which the nerve impulse travels along the nerve fiber. For this reason, myelinated fibers are considered fast-conducting fibers. The nerve impulse travels the length of the axon. However, the signal does not jump from one neuron to the next. A synapse helps information move chemically from one neuron to the next. All the previous occurs just in one neuron. So to get to the other neuron, there has to be a synapse. And there are parts to the synapse. The synaptic cleft, and that's the space between the neurons, and you will see this in figure 1010. The receptors, they only fit, remember we talked about this before, the receptor only fits a certain neurotransmitter. It's kind of like a lock and key. So there's receptors, there's neurotransmitters, and we've talked about those chemical substances stored on the axon terminal of a neuron. The most common are acetylcholine, ACH, and norepinephrine. We've talked about those. And inactivators. These are substances that terminate the activity of the neurotransmitters. So you need to go back and look at figure 1010 and understand how this nerve travels through the neuron and how it gets to another neuron through a synapse. Moving on to the brain requires 20% of all the oxygen that we have. The primary source of energy for the brain, and you should remember this, is glucose. When blood glucose levels get low, and that's called hypoglycemia, a person will experience confusion because there's not enough oxygen being produced that can get to the brain, and so the patient can become confused. Now, there's other reasons. We don't want to get too much off track, but if the heart is not pumping strong enough, then it's not pumping that blood through the body, remember, and that blood's not getting to the brain, and therefore less oxygen is getting to the brain. So there's various reasons why, but for sure, if there's not enough glucose, then the patient can become hypoglycemic and can get confused. The four major areas of the brain are the cerebrum, and that's the largest part, and it's divided into the right and left hemispheres. The bumps on the brain are called gyri, and they are separated by grooves called sulci and fissures. These separate the cerebrum into lobes. So you probably have learned this in high school: the frontal lobe, the parietal lobe, the occipital lobe, and the temporal lobe. The frontal lobe is here, and it's the motor area. It involves personality, behavior, emotional expression. It involves intelligent function. In other words, they lose their sense to go from A to B to C. Their analytical sense is gone. Their memory storage, they usually have short-term memory. So if someone has a stroke and it's affected the frontal lobe of the brain, you will see that patient's personality changed. The parietal lobe is mostly concerned with receiving general sensory information from the body. So the patient would lose a lot of the ability to sense information. Temporal lobe, that usually involves the ear and nose, tongue, translation of thought into words. So the patient more than likely would have difficulty speaking, hearing, swallowing. And the occipital is the visual cortex. Injury to the central nervous system cannot be repaired. Thus, the CNS has an elaborate protective system that consists of 4 structures: bone, meninges, cerebral spinal fluid, and again the blood-brain barrier. The meninges form a brain pad. It's called the pia mater, the arachnoid mater, and the dura mater. Cerebral spinal fluid is the 3rd layer of protection, and it is formed from the blood within the brain. It is a clear fluid that looks like a clear soda and is similar in composition to plasma. Cerebral spinal fluid is formed within the ventricles of the brain by a structure called the choroid plexus. The choroid plexus is a grape-like collection of blood vessels and ependymal cells and is suspended from the roof of each ventricle. As the cerebral spinal fluid leaves the ventricles, it follows 2 paths. Some of it goes through a hole in the center of the spinal cord called the central canal and eventually drains into the subarachnoid space at the base of the spinal cord. The rest of the fluid flows from the 4th ventricle laterally through the hose into the subarachnoid space that encircles the brain. So if a patient is having a stroke or a brain bleed, usually a brain bleed, it may be in the subarachnoid space, and there will be cerebral spinal fluid that could leak from that area. So that's kind of a quick chapter 10. Make sure you read terminology, disorders of the brain, and the summary outline at the end of this chapter under Get Ready for Exams, I found also to be very good in helping explain these terms. Moving on to chapter 11, the nervous system, the spinal cord and peripheral nerves. The spinal cord is a continuation of the brain's stem. The anatomical arrangement of the spinal cord forms the basis for the site of a lumbar puncture, and you may be asked to assist a physician with obtaining a lumbar puncture. And this is what you're doing. You're obtaining a specimen of spinal fluid. Spinal cord injuries can cause quadriplegia, which is paralysis of all 4 extremities. Paraplegia is the lower extremities are paralyzed. So very dangerous, diving off of diving boards, doing flips in the house off of furniture, things like that, football, anything like that can cause a spinal cord injury. The tracts of the spinal cord, what they call desiccate, or they cross over. If a patient has a stroke on the left side of the brain, the nerves cross over and the patient can be paralyzed on the right side of the body. So those spinal cord nerves cross over one another. Some fibers do not cross over, and so a patient who has a stroke in the left brain may experience both a right-sided paralysis and left-sided weakness. But usually, if they've had a stroke or a bleed on the right side, you will see issues with the left side of the body. A reflex is an involuntary response to stimulus. The knee-jerk reflex in the text illustrates the 4 basic components of the reflex arc. And you can see that in one of the figures. The reflex arc is the nerve pathway involved in a reflex. The four components are: there's a sensory receptor, an afferent or a sensory neuron that carries the nerve impulse, an efferent or a motor neuron that carries the impulse to the muscle, and an effector organ is the muscles of the extremity then move. So that knee-jerk reaction. There are many reflexes: withdrawal, pupillary, blood pressure, we've talked about that, baroreceptors, and the Babinski. We haven't talked about that. You may have already heard it though in one of your clinicals, but Babinski, you definitely need to know. You'll see physicians doing that. You will be responsible for doing that. You stroke the lateral sole of the foot, which causes the toes to curl, and this is normal. If you do this to a baby, his toes will widen upwards, and this is called a positive Babinski. So you don't want a positive Babinski, but for a baby, it is normal. Just remember that. So you can picture in your mind how a little baby flips up their toes. Okay, that is what is abnormal in an adult. And you can look at that at 11.2. The peripheral nervous system consists of the nerves and ganglia located, as we said before, outside of the CNS. Nerves are classified as sensory, motor, or mixed. The peripheral nervous system can be classified in two ways: structurally by the anatomy, and functionally according to what they do. The structural classification of the peripheral nervous system divides the nerves into cranial and spinal nerves. The classification is based on the origin of the fiber where it originates. Cranial nerves exit the brain and generally supply the head, neck, and shoulder areas. There are 12 pairs of cranial nerves in figure 11.7. Each cranial nerve has a specific number, always designated by a Roman numeral and a name. You will need to memorize the cranial nerves in figure 11.7, plus that is part of your homework. Also on table 11.3, notice that there is a mnemonic on how to remember the nerves. On old Olympus towering tops a thin view, Germans vaulting and hopping. The first letter is how you're supposed to, if you remember that phrase, which I never was too good at that, but if you can remember that phrase, then that helps you remember the different nerves. Also, the table on 11.3 shows you the type and function of the nerve. Please note that sometimes more than one nerve affects the same organ or sense. Example, movement of the eyeball is affected by more than one cranial nerve. So when you look at that figure, go over there and kind of review that and understand that not all, that some of the cranial nerves affect different organs. So the eye is affected by more than one cranial nerve. Again, on table 11.4, there's a list of assessment and disorders, and you will need to know these. A dermatome is a sensory thing. Each dorsal root of a spinal nerve innervates a particular area of the skin. This distribution of nerves is called a dermatome, and that's in figure 11.9. So all of these are sensory perceptions and our nerves and how all of that comes together. As the spinal nerves exit from the vertebral column, they divide into many fibers. At various points, most nerve fibers converge or come together again into nerve plexuses or networks. The three major nerve plexuses are the cervical, the brachial, and the lumbar sacral plexus. Table 11.5 describes which spinal nerve is the origin and which regions are innervated and the major nerves emerging from the plexus. The phrenic nerves are part of the cervical plexus. The phrenic nerves serve the diaphragm, and we talked about that in one of the earlier chapters. Damage to the phrenic nerves can cause an impaired breathing. The brachial plexus involves the axillary, radial, median, musculocutaneous, and ulnar nerves. Damage to the axillary nerve can cause severe pain, or damage to the median nerve can cause carpal tunnel syndrome. And everyone is familiar with the lumbar sacral plexus, and and the effects of or irritation of the sciatic nerve. Especially in nursing, you'll need to really protect your back and not want to hurt your sciatic nerve, because it's a long-term problem. But what I learned nursing at the bedside after I hurt my back was to always make sure you raise the bed up. As an example, if you're going to start an IV, try not to bend over. Get your work area up to a level where you don't have to bend over, because once you've done that 15 years, then you're going to have some sort of more than likely problem with sciatic nerve or some other kind of a nerve problem in your back. So be sure and protect your back. You're young, and listen to your instructors and try to raise that bed up and get help lifting patients, all kinds of tricks to help you maneuver these patients. Chapter 12 is the autonomic nervous system. The automatic way of doing our work, or our body systems work. When you eat, you do not think to, oh, I'm gonna produce some digestive enzymes now, but your body automatically does that for you. A visceral reflex is mediated in a manner similar to the knee-jerk reflex. Activation of a receptor, transmission of sensory information to the CNS, the processing of the information, and the motor response sent to the effector organs. An example, a sudden decrease in blood pressure activates the pressure receptors, remember the baroreceptors. The information about the low blood pressure is carried to the medulla oblongata of the brain by sensory nerves. So they've sensed that the blood pressure is low. The medulla oblongata determines that the blood pressure is low and sends motor signals to the visceral effector organs, the heart and blood vessels. The motor response results in changes in the heart and blood vessels that help elevate then the blood pressure. So the heart beats faster, the blood vessels constrict, and that helps raise that blood pressure. So what's been accomplished? A sudden decrease in blood pressure stimulated a visceral reflex that restores blood pressure to normal, and all is done without our conscious input. And that's what I find completely amazing about nursing and anatomy and biology, and I've probably told you this before, but I'm amazed at how sodium and potassium, A, are in our body, but B, how they can change the way neurons transmit impulses, and how, without us even consciously understanding, okay, our blood pressure's down. So all these things happen with our organs, our circulatory system. I just find the whole thing amazing. And I think as you go through nursing, you will do the same thing. I hope you see the body is an amazing instrument. Now I'm off my soapbox. The autonomic nervous system is part of the peripheral nervous system that supplies motor activity to the effector organs, glands, smooth muscles within organs and tubes, and the heart. The two divisions of the ANS are the sympathetic and the parasympathetic, which we have talked about. As you know by now, the sympathetic nervous system is activated during periods of stress or time when a person feels threatened. So you have fight or flight. Your heart will race, your pupils will dilate, you will breathe faster and deeper, the palms of your hands will sweat, your mouth will become dry. The parasympathetic nervous system calms everything down. It decreases the stress and helps just slow everything back down. The peripheral nervous system plays an important role in the regulation of digestion and in reproductive function. For this reason, it is sometimes referred to as the feed and breathe division of the autonomic nervous system, or it can be referred to as the resting and digesting. During severe times, the heart rate can brady down, get too low, remember bradycardia, and cause a dangerous situation. Bradycardia, the heart rate is less than 60. Many drugs work by altering autonomic activity. As you're studying now in pharmacology, you will need to understand the autonomic nervous system terminology. So a sympathomimic drug is one that causes similar effects to the activation of the sympathetic nervous system. So when you study pharmacology and you see that classification of drug, you will know that that drug will do what the sympathetic nervous system does, which is speed everything up. So this drug will increase heart rate, force of cardiac contraction, and blood pressure. These drugs are also called vagomimic. Sympatholic is lytic means inhibiting. So the administration of this type of drug prevents an increase in cardiac activity when the sympathetic nerves are fired. So what would it do? It would slow the heart rate down. A parasympathomimetic is a drug that causes effects similar to the activation of the parasympathetic nervous system. So this drug will decrease heart rate, increase digestive activity. These drugs can also be called vagomimic, as they have similar effects to the parasympathetic activity. Parasympatholic is a drug that prevents activation of the parasympathetic nervous system, and these drugs are also called vagolytic. A drug often used that is considered a vagolytic drug is atropine. If the heart rate, as we talked about earlier, becomes dangerously low, you're probably going to be in a code blue at the hospital or in a doctor's office or in a long-term care facility. And then the physician will order atropine. If you're in long-term care, probably the paramedics are there and they will administer atropine. That's a life-saving drug. It's one of the first drugs I ever learned when I was moved to ICU many years ago. They opened the crash cart and said, you need to learn all these drugs. And I remember the first one was atropine, and I gave it many, many times over the years. It's a life-saving drug, and when a patient is coding, you give them atropine, and that helps usually speed up the heart rate. The autonomic nervous system neurons, the neurons of the sympathetic nervous system leave the spinal cord at the thoracic and lumbar levels. The sympathetic nervous system is therefore called the thoracolumbar outflow. The neurons of the parasympathetic nervous system leave the CNS at the level of the brainstem and the sacrum, and therefore they are called the craniosacral outflow. Cranial nerves. Parasympathetic fibers travel from the brainstem with 4 cranial nerves. So they're leaving the brainstem. The ocular motor, the facial, the glossopharyngeal, and the vagus. The vagus nerve carries over 80% of the parasympathetic nervous system. It travels from the brainstem to the organs within the thoracic and abdominal cavities. Neurotransmitters we talked about. The 2 major neurotransmitters are acetylcholine and norepinephrine. The neurotransmitter is used to name the fibers of the ANS. For example, a fiber that secretes norepinephrine is called an adrenergic fiber. A fiber that secretes acetylcholine is called a cholinergic fiber. And this will also become very important to you in pharmacology, because you will find that we have classifications of drugs: cholinergic drugs, and adrenergic drugs. You need to review figure 12.2a and b. There are 4 fibers. 2 are pre-ganglionic and 2 are post-ganglionic fibers of the sympathetic and parasympathetic nervous system. All pre-ganglionic fibers secrete acetylcholine and are therefore cholinergic fibers. So just get those terms together. Pre-ganglionic secrete acetylcholine, and those are cholinergic fibers, or what you will find are cholinergic drugs. The postganglionic sympathetic nervous system secrete norepinephrine and are called adrenergic fibers. So to kind of sum that up, and it's a lot of terminology for you, the 2 major neurotransmitters of the autonomic nervous system are acetylcholine and norepinephrine. You know that. acetylcholine is secreted by the cholinergic fibers. The effect of acetylcholine is short-lived. Norepinephrine is secreted by adrenergic fibers. The effects of the sympathetic nervous system are primarily caused by norepinephrine, and that speeds things up, fight or flight. Remember, if the patients are taking amonoamine oxidase, or MAO, is an enzyme that breaks down norepinephrine in the central nervous system. An MAO inhibitor drug prevents the breakdown of norepinephrine and is used in the treatment of depression. So people on these drugs have epinephrine already on board. You will often see medications that say do not take this if you're on an MAO inhibitor drug. So that'll be interesting for you to watch if you've never noticed that. It's on a lot of medications. Do not take this if you're on an MAO inhibitor drug because the patient already has a lot of epinephrine on board. Moving on to Chapter 13, the sensory system. Sensory neurons transmit information to the CNS. A receptor is a specialized area of the sensory neuron that detects a specific stimulus. Example, the receptors in the eye respond to light. The receptors on the tongue respond to chemicals in food. There are 5 types of sensory receptors: chemoreceptors, nociceptors, thermoreceptors, mechanoreceptors, and photoreceptors. Chemo are stimulated by changes in chemicals such as hydrogen ion and calcium. Nociceptors are pain. Thermoreceptors are temperature. Mechanoreceptors are movement of changes in pressure or movements of body fluids. Photoreceptors are stimulated by light, and those are on figure 13, table 13.1. The general senses include pain, touch, pressure, temperature, proprioception, which is the sense of orientation or position, which is your equilibrium. These receptors are widely distributed and are found in the skin, muscles, joint, and viscera. The special senses are smell, taste, sight, hearing, and balance. The eyes are organs of vision. They contain the visual receptors. The eyes also have an accessory organs, including the eyebrows, the eyelids, conjunctiva, the eyelashes, the lacrimal apparatus, and the extrinsic eye muscles. The eyeball is recessed and is surrounded by a layer of orbital fat. Remember, we studied about Graves' disease and how that orbital fat makes that eye protrude. The eyeball is composed of 3 layers: sclera, choroid, and retina. The retina is the nervous layer containing the visual receptors, which are sensitive to light and are therefore called photoreceptors. The 2 types of photoreceptors are rods and cones. The rods are scattered throughout the retina but are more abundant along the periphery. The rods are sensitive to dim light and provide us black and white vision. The cones are most abundant in the central portion of the retina and provide us with color vision. The area of the retina that contains the highest concentration of cones is called the fovea centralis, an area in the center of a yellow spot called the macula lutea, and that's in figure 13.8a. Because the fovea centralis contains so many cones, it is considered the area of our most acute vision. A second small circular area of the retina is in the back of the eye. The neurons of the retina converge to form the optic nerve. It contains no rods or cones. This is the area called the optic disc. And you see why we talk a lot about diabetes, because diabetes causes blindness, and it goes in there and damages that optic disc and the retina, and all kinds of damage diabetes can cause. There are 2 cavities in the eyeball, the posterior and the anterior cavities. The posterior cavity is larger and is located between the lens and the retina. The posterior cavity is filled with a gel-like substance called the vitreous humor. This substance pushes the retina against the choroid layer, thereby ensuring that the retina receives a good supply of oxygenated blood. The anterior cavity is located between the lens and the cornea. The anterior cavity is filled with a watery fluid called the aqueous humor. Aqueous humor performs two functions. It maintains the shape of the anterior portion of the eye, and it provides nourishment to the cornea. Drainage of aqueous humor through the canal of Schlemm may become impaired. Consequently, aqueous humor accumulates in the eye and elevates the pressures in the eye. An elevated intraocular pressure is called glaucoma, and that is how glaucoma occurs. Is that pressure builds up because the drainage of that aqueous humor through the canal of Schlemm doesn't occur, and it builds up pressure in the eye, and that causes glaucoma. And glaucoma can lead to blindness because it damages the optic nerve. Normally, glaucoma cannot be cured. Patients have to take eye drops, miotic eye drops, and we'll learn about that in pharmacology. But I have seen it cured at least one time in my life because the patient had cataracts, and the physician went in and created an opening and allowed that aqueous humor to drain, and that person was able to get off of eye drops. The pathway of light waves must enter the eye, the cornea, and focus on the retina. Light enters the cornea through the aqueous humor, through the pupil, the lens, the vitreous humor, and to the retina, or the photoreceptors. The ear. The ear is divided into three parts: the external ear, the middle ear, and the inner ear. The steps in hearing, their sound from external auditory canal reaches the tympanic membrane, which, you remember, the tympanic membrane is the eardrum, causing it to vibrate. Vibrations from the tympanic membrane cause the middle ear bone, the malleus, the incus, and the stapes to vibrate. Vibrations from the stapes is picked up by the membrane of the oval window, causing movement of the endolymph within the inner ear, causing the fluid then to start movement. Movement of that bends the hairs of the cells within the cochlea, or the organ of Corti. The hearing receptors are cells that contain tiny hairs. When the hairs on the receptor cells are bent, a nerve impulse is sent by the cochlear branch of the vestibular cochlear nerve, cranial nerve 8, to the primary auditory cortex of the temporal lobe of the brain, where their sensation is interpreted as hearing. This bending of the hairs classified these cell receptors as mechanoreceptors. Again, I find that absolutely amazing, that all of that can occur in our ear, and tiny little hairs are what send that to the brain and cause us to hear. Activation of the organ of Corti generates electrical signals or nerve impulses that are transmitted by the cochlear branch of the cranial nerve 8 to the primary auditory cortex of the temporal lobe and interpreted as hearing. Amazing. Review the diagram 13.15 and understand the steps in hearing. And review the Get Ready for Exams at the end of this chapter. And that, my students, is the end of Unit 5, and best wishes. Thank you.